In this quick review, we will discuss the implications of this important article published in the Lancet recently. My professor, Dr. Saurabh Datta from PGH Chandigarh, was the first author, and obviously he's an expert on the topic. He has published a full textbook on neonatal sepsis as well. All of us are concerned about the use of antibiotics and the duration of exposure to antibiotic courses. So in newborns, we often believe in longer courses to be on the safer side, but is it really correct to do it that way? So this article, as well as the other related meta-analysis, would give us a little more support in stopping the courses earlier where there is enough evidence that the baby is clinically improving. So basically, it's a meta-analysis looking at shorter or biomarker-guided antibiotic duration for common serious neonatal infections. And this was done on a non-inferiority model, which, according to the authors, is a better way of looking at it. And obviously, the conclusion, it's summarized here by Dr. Saurabh Datta himself. So this was published in the Lancet on 14th October. So 7 days of antibiotic in a culture-proven sepsis is as good as 14 days in terms of non-inferiority if the baby has been free of signs of sepsis by day 5 to 7. This doesn't apply to staph aureus, and as described later, it doesn't apply to complicated meningitis as well. Biomarker-guided antibiotic duration is as good as standard duration. So if you're following the C-reactive protein for early onset sepsis or procalcitonin and CRP for late onset sepsis, if the markers come down to almost the normal range, it's safe to stop the treatment by 5 days, 4 to 5 days or so. The results are equivocal for 3 to 4 days versus 5 to 7 days. Many of us treat for 7 days in a culture negative sepsis where the baby has clinically improved by day 2 to 3 and the markers have come down by day 4 to 5. So if the culture is negative and the baby clinically improves quickly enough, you can safely stop the antibiotics by 3 to 4 days. In my practice, I tend to stop the antibiotics by around the end of the 3 to 5 day period. If the culture is negative, mostly start of the 5 days is when I stop the treatment. If the culture is positive, we tend to stop by 7 days in our unit, in some cases up to 10 days, if the improvement was quick enough. Obviously, shorter duration for urinary tract infection, there is not enough evidence. The same for meningitis, ventriculitis, and fungal infections. These are major infections with risk of complications, so sticking to the norm is probably better in these cases. So it's very important that you document the improvement at every stage. So if the CRP is repeated or the clinical improvement is there, and you document the culture negative aspect, the decision to do a lumbar puncture or not to do a lumbar puncture and any reason why you decided not to do a lumbar puncture, especially in early onset sepsis where it is reasonable not to do, if the baby is clinically well and markers are coming down and the culture is negative, should be documented as well. And all this should be ideally be discussed with the family as well. Towards the end of the article, there is a discussion on why this could be of benefit. Obviously, we know that length of stay in the hospital is not ideal. We give IV antibiotic treatment for the babies, and giving a longer course of treatment in the hospital means the baby stays in the hospital environment longer. The safest bet is to keep the baby at home if we can stop the antibiotics early, so the mother continues to look after as a single caregiver, and the colonization happens with the external bugs and not necessarily with the hospital bugs. So there is a definite advantage, and the cost-benefit analysis would also favor this. So obviously, antibiotic resistance is a big problem, and the risk of serious infection has to be weighed carefully before we start antibiotics or escalate them. But at the same time, if the baby is clinically responding, de-escalation and stopping at the right time is important as well.